Bismillah ar-Rahman ar-Rahim. We will start to talk about the anatomy of the larynx and the benign lesions of the larynx. Topics for discussion: anatomy of the larynx, physiology of voice production, benign lesions of the larynx. Anatomy of the larynx. The larynx is made of hyoid bone, which is one of the important bone at the level of the C3 cervical vertebra number 3. 9 cartilages, 3 paired and 3 single cartilages, ligaments, membranes, and 2 sets of muscle, the intrinsic muscle and the extrinsic muscle. The intrinsic muscle, which is responsible to control the tension and orientation of the vocal cord. Extrinsic muscle, which is responsible for adjustment the position of the larynx during swallowing. Respiratory mucosa cover the anterior surface of the larynx, is continuous above the pharynx and below to the trachea. The thyroid cartilage, the most prominent and largest laryngeal cartilage. The angle of diffusion in men 90 degree and in women 120. The cricoid cartilage located at the level of C6. It has a signet ring shape. It is the only cartilage that forms complete ring in the respiratory system. It is a complete ring. It is thicker and stronger than the thyroid cartilage. The epiglottis at the level of C5. The arytenoid cartilage, corniculate, and cuneiform cartilage, which are considered as a paired cartilage. The ligament, extrinsic ligament and the intrinsic ligament of the cartilage. The first extrinsic ligament, the thyrohyoid membrane, which is connecting the thyroid cartilage with the hyoid bone. The intrinsic ligament, quadrangular ligament, the inferior edge continuous with the vestibular ligament. The cricovocal membrane thickened anteriorly to form the conus elasticus, which is one of the important landmark in the erosion of this part of the anterior cricothyroid membrane and the invasive lesions in the larynx. The mucosal lining of the larynx is closely attached over the posterior surface of the epiglottis, corniculate, cuneiform cartilage over the vocal ligament, and also it is firmly adherent at the laryngeal surface of epiglottis, and it is loosely adherent in other area in the larynx. At this point it is an important part in the process of development of anaphylaxis and severe laryngeal edema. The latest and the area to be prone with the swelling and to close the airway is the vocal cord and the laryngeal surface of epiglottis. The true vocal cord, the epithelium, it is stratified non-keratinized squamous epithelium. The other layer, the first layer, it is an epithelial layer, followed by the lamina propria. The lamina propria, which is divided into certain layers. The deepest layer, which is the vocalis muscle, medial part of the thyroarytenoid muscle. The larynx is subdivided into supraglottic area, glottic area, and the subglottic area. The supraglottic area, which is from the superior part from the epiglottis to the superior border of the true vocal cord. The glottic area from the vocal cord down 1 cm below the free border of the true vocal cord, من 0.5 to 1 cm below the free border of the vocal cord to the inferior border of the cricoid cartilage, which is called the subglottic area. We will talk about the intrinsic muscle of the larynx. All the intrinsic muscle of the larynx are supplied by the recurrent laryngeal nerve except the cricothyroid muscle, which is take nerve supply from the external branch of the superior laryngeal nerve, which is responsible for increasing the pitch of the sound and to elongate and to increase the tension of the vocal cord. The main abductor, which is the posterior cricoarytenoid, the lateral and the transverse cricoarytenoid, which will adduct the vocal cord, thyroarytenoid muscle, which shorten and thicken the vocal cord. As we said, the two branches of the vagus nerve, superior laryngeal nerve and the recurrent laryngeal nerve. The superior laryngeal nerve divided into the external and internal branch. The external branch motor to the cricothyroid muscle. The internal branch, which is sensory at and above the level of the glottis, يعني superior part of the larynx. The recurrent laryngeal nerve supply all the intrinsic muscle of the larynx except the cricothyroid, and it will carry sensation from the glottic subglottic below the level of the vocal cord. The infantile larynx, it has big and important difference between the adult and infantile larynx. The infantile larynx, it's high in position, which bring the epiglottis and the palate into close proximity. Yani when we are examining the oropharynx by the tongue depressor, when we depress the tongue base, we can see the superior part of the larynx, which is called the supraglottic area. There is overlap lead to formation of two separate pathways, first for feeding and second for breathing. The child cannot drink fluid and breathe in the same time. Obligatory nasal breather in the first few months of life. This overlap is usually constant but may be interrupted during crying, swallowing, and dense voice. At the birth, the larynx at the level at C4, at 2 years C5, at 5 years at 6 C6, at the 15 years age at the level of C7. Hoarseness in voice, general term which will describe the abnormal voice change. Difficulty in production, the sound when trying to speak, change in a pitch and the quality of the voice. The voice may sound weak, very breathy and scratchy or husky. When we talk a history about the laryngeal disorder, the nature and the chronology of the voice problem, which is one of the important point of history, persistent hoarseness of voice or change of voice more than 3 weeks, we have to completely investigate the larynx to check the cause. Exacerbating and the relieving factor, lifestyle, dietary condition and hydration issues, patient voice use requirement, medical and drug history. There is certain drugs and medical illnesses which may has a big influence on the character of the voice, especially the selective serotonin reuptake inhibitor and the antidepressant drug, which may cause severe hoarseness of the voice and severe dryness in the throat. Impact on the quality of the life, risk factor of causes of the hoarseness of voice. Physical examination, we have to check any patient with laryngeal problem. We have to check the nose and the ear, neck, lymph node, visualization of the larynx by certain methods, indirect laryngoscopy by mirror, by fiber optic direct, by fiber optic nasolaryngoscopy, and direct rigid laryngoscopy. This picture show how we can examine the larynx indirectly with the mirror. At the first photo or picture, warming of the mirror, then we grasp the tongue anteriorly and we try to check the larynx indirectly. The second picture, the flexible fiber optic nasolaryngoscopy, it is one of the visual system procedure with the specific fiber optic cord. It will pass through the nose down to the larynx under complete visual system. This picture showing the normal laryngeal structures as we see from anterior. This is the anterior part of the vocal cord, which is the whitish area. The upper part, this is the false vocal cord, but then there is a arytenoid cartilage, aeroepiglottic fold. The posterior part, which is the cricopharyngeus, lateral to the aeroepiglottic fold, which is the piriform fossa or sinus. Below the level of the vocal cord, which is the subglottic area, then followed by tracheal rings. Voice production and physiology of the voice production. The vocal cords are kept adducted. Infraglottic air pressure is generated by exhaled air from the lung due to contraction of thoracic and abdominal muscles. The air force opens the cord and is released as a small puff which is vibrate the vocal cord and produce sound which is amplified by mouth, pharynx, nose, and the chest. Cord may not be able to vibrate probably in the presence of congestion, submucosal hemorrhage, nodules, and polyps. Causes of the hoarseness of voice, there is different causes: congenital, inflammatory, neoplastic, neuromuscular, miscellaneous causes. One of the important of the benign conditions of the larynx, acute laryngitis, which is infectious type or non-infectious type. Infectious follow upper respiratory tract infection, almost often viral in origin. It may be superadded by bacterial infection. Non-infectious type, secondary to vocal abuse, allergy, smoking, alcohol consumption, thermal chemical burn, laryngeal trauma. The main presentation of acute laryngitis: aphonia, dysphonia, cough, stridor. When the patient reaches this stage, it is a potentially serious condition. Pain in throat after talking. In examination, indirect laryngoscopy, we will see red swallowing larynx. Sometimes we presented with thick strings of mucus between the vocal cord. The main management of the acute laryngitis: voice rest and avoidance of smoking and alcohol. Voice rest means keep the patient to take in a normal tone, not in a high-pitched tone or hypo-pitched or hypo-resonant tone. Chronic laryngitis, one of the important predisposing factor is alcohol consumption, smoking, vocal abuse. Treatment of the chronic laryngitis: voice should be rested, treat upper airway sepsis, steam inhalation, and avoidance and prevention of the predisposing factor. Larynx space and larynx edema. The larynx space, it is one of the subepithelial space between the lamina propria and the epithelium. The main causes of the larynx edema is smoking, voice abuse, hypothyroidism, gastroesophageal and laryngeal reflux. There are this term for condition include polypoidal vocal cord, polypoidal changes of polypoidal hypertrophy, bilateral diffuse polyposis, usually affecting middle-aged women which have long-term smoking, almost always associated with the smoking. It is a benign condition. Examination reveal lower pitch than would be expected. Fiber optic will show edema as we see in this picture in the vocal cord with restricted mobility with stroboscopy. The treatment, conservative treatment with the prevention of the predisposing factor. If persistent after 6 weeks or 3 months, may need surgical intervention. One of the important benign condition, vocal cord nodules, which is common in female under 30, common in children and boys, usually bilateral but maybe unilateral, small swelling, 3 mm in diameter, almost in the anterior 1/3 of the vocal cord between the junction of the anterior membranous and the posterior 2/3 of the vocal cord. The treatment of the patient with vocal cord nodules who will present with persistent hoarseness of voice, aggressive speech therapy is the mainstay. Failure of the speech therapy may need microlaryngeal and exogenal treatment. Vocal cord polyp. A true vocal cord polyp is a benign swelling of the which is greater than 3 mm. It arises in the free edge of the vocal cord. More common in male between age of 30 and 50 years. Most need surgical removal. Benign lesion of the respiratory tract, recurrent respiratory papillomatosis, which when one of the common condition, the most common site of aerodigestive system affected with recurrent respiratory papillomatosis is the larynx. The second most common cause of hoarseness of voice in children. The causative microorganism is human papilloma virus type 6 and 11. No definite treatment, only palliative treatment, which is The best treatment is microlaryngoscopy with CO2 laser oxygen is debulking of the airway from the polypoidal lesion to keep the airway patent. One of the most important pre-malignant condition which is leukoplakia and erythroplakia. Leukoplakia, it is a localized form of epithelial hyperplasia involving the upper surface of one of the both vocal cord, which is presented with white plaque or warty growth from the vocal cord. The treatment is excision and stripping of this lesion and sent for histopathology and monitoring for possible malignant changes. Vocal cord mobility and vocal cord disorders. One of the important topics we will talk about is the vocal cord paralysis. The most common cause of vocal cord paralysis is iatrogenic injury following a surgery. The most common surgery is the thyroid surgery, as we know, the recurrent laryngeal pathway in the thyroid anatomy. Also, the injury of the recurrent laryngeal nerve and the vagus nerve at the anterior cervical fusion surgery, esophageal carotid endarterectomy, mediastinal surgery. Also, of important causes of vocal cord paralysis: neoplastic, bronchial tumor, nasopharyngeal, esophageal, thyroid, lymphoma, idiopathic type, which considered as a self-limiting condition, a neurological disorder, trauma, infectious, systemic disorder, and toxins. As we see in this picture, there is a left vocal cord paralysis. Any patient presented with unilateral or bilateral vocal cord paralysis, we have to do a complete diagnostic workup. Fiber optic nasolaryngoscopy is the mainstay to assess the mobility of the vocal cord. Then we have to assess the course of the recurrent laryngeal nerve, the nerve supply from skull base deep to the mediastinum to localize the problem and to evaluate the entire pathway of the vagus nerve and recurrent laryngeal nerve. MRI if a child pregnant or suspected have generalized neurological problem. The treatment option depend on the severity and of the symptoms. Observation in the unilateral vocal cord paralysis up to 1 year. We can inject the vocal cord to avoid and to prevent spells of aspiration and to correct the voice disorder. Thyroplasty, arytenoid adduction, tracheostomy, one of the treatment of the vocal cord paralysis. Laryngomalacia we'll talk about is the most common cause of stridon in the infantile period. 60% of all laryngeal problems occur due to floppy supraglottic tissues. The patient and the neonate presented with an aspiratory stridor that start within the first 6 weeks of life. Exacerbating factors: sleeping, lying supine and upper respiratory tract infection. Relieving factor: lying prone, and when the child is active, the redundancy and the floppy supraglottic tissue will increase in tone and it will correct the stridor and the upper airway obstruction. The diagnostic golden way to diagnose the laryngomalacia is flexible fiber optic laryngoscopy. 90% of the cases with mild to moderate symptom will improve within the first 2 years of life. Only 10% will need surgical intervention. We will talk about the acute laryngeal infections in the children, acute epiglottitis and acute laryngotracheobronchitis, which is called croup. The acute laryngitis, the common organism of acute epiglottitis, bacterial Haemophilus influenza type B, the croup, parainfluenza type, viral infection type 1 and 2. The age of acute epiglottitis usually at the age of 3 to 5 years, croup earlier in the age. The diagnostic X-ray for the neck, lateral neck, anterior and lateral neck. In acute epiglottitis, it will show the thumb sign, and in croup laryngotracheobronchitis, it show the steeple sign, as we see in the picture on the right side. There is narrowing in the upper airway. The treatment in acute epiglottitis, it is one of the ENT emergency to secure the airway, one of the priority. The patient may need antibiotic and steroid. In acrobe, the patient may need nebulizer, humidified oxygen, and corticosteroid. Stridor, it is an abnormal high-pitched sound produced by turbulence of airflow through a partially obstructed airway at the level of the supraglottic, glottic, subglottic, and the trachea. It should be differentiated from stridor, which is a lower-pitched snoring type sound generated at the level of the nasopharynx and occasionally supraglottic area, which is presented in upper airway obstruction. Stridor is a symptom, not a diagnosis or disease, and the underlying cause must be determined. Inspiratory stridor usually suggests laryngeal obstruction, expiratory bronchial obstruction, biphasic, tracheal, subglottic, and glottic anomaly. There is a multiple causes of stridor. We have to check all these causes. Of the important chronic stridor: laryngomalacia, vocal cord dysfunction, subglottic stenosis, laryngeal web, laryngeal cyst, hemangioma, tracheomalacia, laryngeal papilloma. We will talk about important notes in a patient with upper airway obstruction, moderate to severe distress, emergent management of pediatric airway. It is an important problem. Acute epiglottitis, physical examination is contraindication in acute epiglottitis. When we suspect this is a case of acute epiglottitis, we have to deal without interrupt the patient. Certain positions that elevate the stridor: note the presence of infection in the oral cavity, crepitation or masses in the soft tissue of the face, neck, and the chest, deviation of the trachea. Take care when examining or palpating the oral cavity pharynx, because sudden dislodgement of foreign body or rupture of abscess can cause further airway compromise. Drooling from the mouth suggests poor handling of secretion. Observation of character of cough, cry, and voice. Fever, toxicity generally implies serious bacterial infection. Careful auscultation of the nose, oropharynx, neck, chest help to locate the source and the site of stridor. Growth parameter, especially in evaluation of a chronic stridor. The treatment of stridor is an alarming symptom. Don't let it pass. Medical care, the treatment of stridor must be tailored according to the underlying cause. Emergent management consists of ensuring the airway is adequate. If not appropriate, resuscitative measure must be initiated. Surgical care, severe laryngomalacia may need surgery. Severe laryngeal stenosis, critical tracheal stenosis, tumors, and lesions, all of these need surgical management. Foreign body aspiration requires surgical extraction. Tracheostomy is used to protect the airway. Bypass laryngeal abnormality and stent or bypass tracheal abnormality. Retropharyngeal peritonsillar abscesses have to be dealt with an emergent basis. Moderate to severe stridor should be MBO in preparation for possible intubation, laryngoscopy, bronchoscopy, or surgical intervention. Thank you for your time.